Okay. All right. It appears we have a quorum. So we're going to begin. We do have, my apologies to everyone. I know it's 2:04. We have multiple committee meetings going on at the same time, and we've had some that needed some of our members for a quorum, and we got all that going on. But we're going to begin with HB 1531. Representative LaHood had made a number of changes from our previous meeting, and we're going to let you go to the podium and speak to this matter. All right, turning on the mic at the podium.
All right, I'm on.
You are on,
All right.
Representative LaHood, Chairman LaHood.
Thank you, Mr. Chairman, and thank you, committee, for coming. Thank you, everybody that came. It has an interest in this bill. So I'll start out by saying thank you, committee. The committee process has improved this bill, has brought more clarity to the bill. A lot of the conversation we had, the debate on, I believe it was Tuesday, was taken back to DCH and Ledge Council and others, and we've added some clarity. So I'll go over what has changed. So first, we'll just go to line 12 as an example. We changed an average monthly minimum to a minimum monthly average, and that was clarity, thanks to Representative Mitchell, to make sure that it's understood with no doubt that we're talking about within a month period, that these certain amount of hours have to be met. It cannot be a cumulative average over more than 1 month. And so that was a good improvement to what's an existing statute. So we appreciate that. And we applied that across the board to direct caregivers and to the licensed nursing hours. The other thing that the bill does is, starting on line 29, what it does is it makes sure that when there's fewer residents than 15 in assisted living or 12 in a memory care center, that if one staff is capable of meeting the needs of those residents, then that would be compliant with DCH. The way the rules are interpreted today, even though the law states that the ratio is 1 to 12 in memory care, for example, DCH interpreted that they're not recognizing staff that can float from other parts of the building to supplement care in another wing, like a memory care wing. And so this language is necessary to make sure that the provider can schedule staff in accordance to resident need, and that staff can be fluid to move to parts of the building where they're needed the most. So if some supplies were needed on the other side of a threshold, that staff could leave that wing temporarily and go grab the supplies and come back, versus current rule today is interpreted as there has to be 2 in that wing at all times, even if there's only 1 resident. And so this clarifies and reinforces the 1 to 12 ratio in memory care, basically, and the 1 to 15 ratio in an assisted living setting. I know there's some concerns here that we might hear from some folks, that there's some concerns that this is weakening the work we accomplished a couple years ago in the major transformation. That is not the case. These are minimum standards. There's language in here repeatedly through the bill that says, for example, on line 14 and 15, says, provided, however, that either such ratio is adequate to meet the needs of the resident. So no matter what the stated ratio is, 1 to 12, for example, it must be adequate to meet the needs of the resident. And the Department of Community Health is going to survey to that standard. If they come to do a survey and the needs are not being met, they're going to write up the provider, and there's going to be consequences for that, whether it's a fine or citation or whatever it is. And House Bill 987 from a couple of years ago clarified that, increased fines. It also required certification of an administrator of these type of facilities for the first time ever. It required licensed nurse presence for the first time ever. It required a memory care center to be certified for the first time ever. Required all sorts of things that are still intact. So all this bill does is clarify and reinforce the ratios that we put into place. And I'll add this too. Before House Bill 987 a couple of years ago, the ratio in a memory care setting was 1 to 20 during the day, during waking hours, and 1 to 25 during non-waking hours. Today, it's 1 to 12 during waking hours and 1 to 15 during sleeping hours. That's what my bill reinforces. And that's what 987 intended. But the way the rules were written, that's not how it's working in real life. And so this is the fix for that. In real life, what's happening is a memory care center has to have 2 at all times, whether your resident count is 1 or 12. So between 1 and 12, you have to have 2 caregivers, regardless of their care needs, and regardless of the 1 to 12 ratio that we intended. I'll be glad to take any questions if there are any.
Okay. We do have some questions. I'm going to first make a comment because I want to make sure that I'm clear on one of the things you said, Representative Hood. When you mentioned that the way it's being interpreted by DCH, I want to be clear and fair to DCH. Is it that certain surveyors who might work for healthcare facility regulation are interpreting the rules that way, or is it in fact that DCH itself is interpreting it that way? Which I want to make sure I understand.
So when we were drafting legislation for 987 a couple of years ago, we didn't define the term on site,
Right.
And we're still not. I've talked with the department about this, and we've determined this language in the bill is the best way to handle it. But by not interpreting on-site, what happened was the department took the position that on-site meant on-site in a wing. For example, a memory care wing, instead of on-site on the premises in the building. And the way this works in real life, most of these licensed facilities have, say, if there's 100 beds, just for easy math, a typical ratio is about 70% are dedicated to assisted living or personal care, and about a third, are dedicated to memory care. That's a common ratio. It's not the case every time. And so, because there's usually more residents in an assisted living or personal care wing of the building, there's more staff there, and that's usually where your support staff are. That's where your housekeepers are based, your maintenance staff, your administrative staff, your dietary workers. But they can also be trained in dementia care. A lot of them are cross-trained, and they're fluid. They're available to float around the building to where the needs are, depending on the time of day, the activities going on. But the position the department took doesn't recognize the staff unless they are dedicated 100% of the time in that particular wing. And there's a lot of situations around the state where you have a small resident count in a memory care wing, fewer than 12, for example, where if today's rules stand and aren't changed, then you're going to put them out of business. And these are located in communities to where if these facilities go out of business, there's going to be no options for consumers other than maybe a skilled nursing facility that costs a lot more if you're comparing apples to apples, private pay, or the resident's not going to be able to afford it, and they're going to go on government assistance, and you're going to pay for it. And so we're offering a solution that doesn't cost taxpayers, and that the residents can pay themselves, which most prefer to do if they can.
Okay, thank you, and we've got several questions here. Just, I think, clearly I think what I'm hearing from you is, you have let's say you have 5 people in a memory care unit, the ratio, you're far below the ratio that is required in the broader bill. But right now you have a conundrum where it says 2 direct care staff at all times. So you've got to you've got to accommodate that, which puts you well over your staffing requirement. And so I think I understand what you're getting at. We'll go to the first question. Is Representative Allen? Is that you down there? 16? All right.
Thank you, Mr. Chairman. Just for clarity, where in the bill are you fixing the on wing versus on site? I'm just not seeing where that is. It's the first question. I have a second one, but
Right.
where exactly are we fixing that?
Yeah. So I talked to the department about that, and we decided the language in this bill, this sub you're looking at, was the best way to handle it. We tried a definition for on-site, and the department had concerns that they wouldn't be able to survey to that definition. We want clear lines, and we can have clear, bright lines, and the department needs that. I think that's better for everybody, really, and this makes the lines as clear as I knew how to make them. The on-site definition was going to recognize people on the premises that could be available to float. But if the department was there on site and observing, they were concerned they wouldn't be able to survey and enforce that type of provision.
And second question, just to that point, if we're not codifying and giving definitions of some of those things, what's preventing a reissuance of the rule? Because from the way I read it, can't the department just reevaluate and reissue the rule? Because this is not actually spelling out or defining what you're saying you're trying to accomplish. I get what you're trying to accomplish, but I'm not sure that this legislation does it, because it's still going to be left up to the interpretation of the department to come up with a rule.
This language would require the department to promulgate rules, per the language here.
But you're not defining anything further. So why can't they? And maybe the department can answer. But if you were defining on site and getting to that target and codifying that so that they had no choice but to go inside of the parameters of that, I would understand better. I'm just not sure what this enables that the department can't do through a reissuance of the rule.
Well, if you look at line 29, what this bill does, this says, provided, however, that only one direct care staff person shall be required to be on site at all times if there are fewer than 15 residents during waking hours or 20 during non-waking hours. Now, this is not referring to memory care. This is referring to the non-memory care parts of the building. But that same language is in the memory care section, too. So this is clarifying that in certain situations when the resident count is below, for example, 12 in memory care, that one staff person could satisfy the requirement.
And I'm going to let it go, but you just said you can't define on site. They'll do that in rule. I just don't understand, by even putting it in here without a definition, it's still going to be left up to the department to interpret and issue the rule. That's my concern. Maybe we'll get to it when some others speak.
Right. Well, the department has taken the position that on site means in that specific wing, memory care wing. That's the position they've taken.
Even without this legislation?
Yes.
It's the same position.
Right.
Yeah, thank you, Representative Allen. I think that's a good point. I mean, yes, the department has the ability to promulgate rules with the current statute and with any changes that we make. That is correct. Who is 11? Is that Representative Mitchell?
Yeah.
Okay, you're on.
Thank you. I had a question. The example you gave was talking about when you had 2 staffers in a wing, that you would not at this point be able to send one to go do something else. Is that correct? So if we change this rule, then you have 1 staffer in a wing. You still wouldn't be able to send that person, because then there will be 0, correct?
That's right. And the provider will have to plan for that. And the typical way that would be planned for is like I said, in a typical situation, you have a larger population of non-memory care residents where there's an abundance of staff, a lot of times excess staff, way above and beyond the required ratio, because you have your administrative staff, your support staff, housekeepers, dietary, maintenance, are housed or stationed in the larger part of the building. And so what typically happens, activity directors, that's another common position. And what typically happens is, staff will float in and out to relieve a staff member that's on duty. And again, most of the time, there's going to be more than one staff person in the memory care center. This bill would solve a problem for smaller memory care centers, or memory care centers with a lower census, or with a lower acuity, meaning the resident needs are low. They're high functioning typically. And allow the provider to operate more efficiently, which that efficiency would then be realized and enjoyed by the consumer. Without the efficiency, the cost is having to be passed on, and in a lot of cases, it's unaffordable.
If you did have less than 12 people in your memory care unit, what is the break-even point at which one would no longer operate that unit? So if you had fewer than X individuals in it, at what point would that no longer be making sense to maintain?
There's not a blanket answer for that, because there's all sorts of situations. It depends on the market you're in. The operator, other than labor, which is the most expensive, the highest expense in an operation like this, you got insurance, you got food, you got a rent on the building or a mortgage on the building. You've got maintenance. You've got administrative overhead. But if you take two staff members at $15 an hour, that's $30 an hour combined. Add a 20% payroll burden for benefits, taxes, that kind of thing. That's $36 an hour times 24 hours a day. That's $864 a day times 365. $315,000 a year.
So is it reasonable to say you would not generally be operating a larger unit without it having sufficient residents that it would be economically viable? So really, when we're talking about this fewer than 12, we're probably not talking about a unit that has one or two people in it, but generally it'll be on the higher end of that. Is that a reasonable assumption?
If I understand your question right, there's not a blanket answer for that. It depends. This is a private pay offering. So if you had a loved one who was having memory impairment and needed care that you were unable or just not able, to provide yourself, you would look for options, and this might be an option. And you would typically, the family or the loved one would go tour, talk to administration, show up for visits unannounced just to kind of see how things go, and decide where they want to invest their money, for the care they need. Usually a smaller memory care unit is, I'd say, a more pleasant environment than a large one. If you get too many memory impaired people together in one facility, in one wing, it can get kind of difficult to manage. Not saying it's impossible to manage, but depending on the acuity, the behavior, those kind of things, the more memory impaired people you have together in one place, just the more potential you have for different challenging scenarios to pop up. But going back to your scenario, the two caregivers at $15 an hour is costing, in my quick math, I would want to go back and verify, but it's about $27,000 a month minimum, and that doesn't include your food service, maintenance, housekeeping, licensed nurse that's now required in this bill. So you'd add that to it, insurance, mortgage, grounds maintenance, transportation to and from doctor's appointments. It adds way up, and so we might be at $50,000 a month. And so it takes usually a larger facility with a larger non-memory care population to sort of support and supplement the memory care. You don't see a whole lot of standalone memory care centers, and that's the reason.
Thank you. Follow up, Representative? Follow up question? Yeah, go right ahead. I'm sorry.
Just from hearing that, it sounds like it is unlikely that what we're looking at here is scenarios where there's one or two people, just because that cost would be so prohibitively high. So really, when we are talking about moving from 1 to 2 folks on site, it is for a larger number in that bracket of how many residents there could be, just because your costs are high. So we should, like, when we understand what impact this will have,
It will
we
help
are
me-
asking somebody to watch 11 people by themselves rather than 2.
I can tell you with full assurance that this will help to keep the doors open. Without this bill, you're going to have a lot of facilities in danger of closing or not being developed. I know of at least one planned memory care development that was called off because they just couldn't make the numbers work.
All right. Thank you, Representative Mitchell. Any other members who wish to speak to the sponsor? Any other members? Okay. We didn't have a sign-up sheet. Okay. So do we have anyone who wants to speak to this bill? Anyone here? I see one back there. Come. Mary Lee? Feel free.
As she's making her way up, can I make one more comment?
Yes, sir.
Okay, I wanted to point out that prior to House Bill 987 that passed in 2020, the law and the rules at the time required 1 caregiver to 20 residents in memory care. 987 reduced it to 1 to 12, which I was in support of. But the way the rules were written, it's less than 1 to 12. It could be 1 to 1, or 1 to 2, or 1 to 4, or 1 to 8. So we've reduced it from 1 to 20 down to one-on-one care in certain scenarios. And the 1 to 12 rule, you're going to hear some concerns. Let me just go ahead and point this out too. Current rule allows you to have up to 24 memory care residents with only 2 caregivers. So that's 2 to 24. Just wanted to throw that out there. So everybody's okay with that, with the 2 to 24, but they're not okay with the 1 to 12.
Okay.
Thank you.
Ms. Boatwright, and thank you, Chairman LaHood.
Thank you, Chairman Petrie and
Thank you.
Representative LaHood. I would say, as I already spoke to you on Tuesday, and I won't go through that again, I think our concern with the one person goes back to why HB 987 even came into being, which was cases of, unfortunately, severe abuse in some cases, absolute tragic situations of death in some cases. So I think when we were looking at this, to be really honest, it wasn't 100% about that care. It was about 4 eyes in a building, so that if you have one CNA who's now alone in the building, and unfortunately they're one of those bad eggs, you've got no other eyes on that person. So I think that's where that 2-person piece came in. I've talked, over the course of the last 2 days with Representative LaHood, and I understand, especially when a memory care or assisted living is ramping up, and their census might be 1 or 2 people for a period of time, that perhaps we have, I don't know, an exception for the ramp up period until you get to a certain number, but that is smaller than 12 and 14, in my humble opinion. But that second set of eyes was also about accountability for your staff. And I don't want to put a CNA who is making, unfortunately, a small amount of money per hour into a situation of liability, and they've got, they can't even have another set of eyes to say that person fell. hit them in the head. If it's the other way around, they didn't abuse, neglect, or assault somebody. So I will say to you that second person, that was really the intention of HB 987's language.
Thank you so much. I think we do have a question, Ms. Boatright. Representative Lumsden.
Thank you. I've dealt with some of this in other ways,
Yeah.
but one of the things concerning what you said that crossed my mind, and you can elaborate on it a little bit, but, technology has really, that's the world we live in. We have cameras, we have videos available. Is that not sufficient to help augment? Because we're facing a real problem here with having. I'm afraid I'm getting to that point where, as we age, us baby boomers are beginning to get to that point where we're going to be more and more thinking about what our future might look like, and making sure that we have done the right thing in creating the proper policy to look out for. So we certainly want them to be safe. But does not technology and cameras give us a little bit of a better advantage to be able to do this?
I don't know if I can, answer that. I don't think that was, again, the intention of HB 987. I think it was to always have two people on the floor. And in a memory care unit where the person living with dementia cannot speak to what has occurred to them, what has happened, I think you need that second set of eyes. So I would say in the memory care unit where Representative LaHood just mentioned, you might have more challenging behaviors, and 100% of the people in a memory care unit are in that situation. Right. That would be, out of these two settings, that would be the one that I'm most concerned with, the staffing issue.
Mm-hmm.
So,
and one other, when a resident or a family places, or a person is placed in a contractual agreement, I assume is signed regarding the care that's going to be given. In that agreement, is that not laid out that that's a possibility, that, or about the ratios, about 1 to 12 or 2 to 24? Are those not laid out in the contractual agreement that the person going into the facility, that their family would sign?
well, I don't, that's in the regs. I don't know that then assisted living actually has to put that in a signed agreement with their residents. To be honest, I don't know if that's,
Okay.
and I don't know that changes anything necessarily if a family knows. Are you saying that if they know they're only going to have one caregiver, they could choose to not take care there?
There are, the options, but the options may be limited. But we're talking about a business practice and a contractual agreement.
Yeah. I mean, and to your point about workforce, the aging advocates have been talking about our aging population for 10 years now. And so it's unfortunate that we went well over the hill with this workforce crisis. But I don't think we should change care standards because of that crisis. We need to come up with some other solutions. And even if that means possibly delaying implementation or giving them a period of time to come in compliance, I'll just say that as an option.
Okay, let's go to another question. Representative Hill.
Yes, thank you. And thank you for being with us. Do you know, mine's just a question, do you know by chance what the ratio is of visitation by family members to these folks?
I don't. I
Because
think
what
that's
I'm
going to
hearing,
vary.
I'm hearing that it's not very often once they put them in there.
In the families that we serve, I would disagree. I mean, I have several families that go every day, and when COVID happened, that was awful because they couldn't. So
Would they
I
not
think
monitor?
in these settings where you're paying this cost, I think you're coming frequently, in my opinion. But again, I don't think that's probably anecdotal.
I'm just wondering, would they not be monitoring their family member then as well? I would. Thank
Yeah.
you. Thank you.
Yeah, I've heard people talk about in this, I had an aunt with dementia. I had 3 in my family with dementia. I had an aunt that was the sweetest person in the world in Waynesboro, Georgia, and they found her walking down the street. Great aunt. She was the nicest person during the day. During the night, she tore up the people's place. And the next morning, she was nice again with her little stuffed kitty. And I'm hearing here one direct person, doing walking hours. That's the daytime, I'm assuming. And in the nighttime, you talk about, and one direct care person for every 20 residents. My question then, what is the starting salary? Because it takes a special kind of person. And I heard someone say $15 an hour, and I'm sure that I do not put these people on the same level as some other people. I think they should be paid more if it was up to me. What is the average salary? And there may be some people that are in the business of a starting salary for someone that has to deal with a person with dementia.
I think
Representative Jackson, I think I'll take that. Miss Boatwright. Miss Boatwright has not been an employer, so I will tell you that I would say Representative Jackson, anywhere from $10 to $15 an hour. You are correct, and it is unfortunate because the example you gave is commonplace, and people that suffer with dementia and Alzheimer's and any number of physical ailments as they age require a lot of care, and our direct care staff all across this state do a phenomenal job for very little, and that's a real issue for us going forward. And so that is absolutely the case, and we appreciate them so much. Any other questions?
But Mr. Chairman, may I ask
I'm
one
sorry.
other-
Yes.
I'm sorry.
Yep.
Then I have a problem, I guess, with this one direct care person during the night hours. Or two people during the night hour. It was walking hours and one direct care staff for every 20 during the non-walking hours. And I can cite other cases within my family. One was one way and one was another way. So is it good to have just one staff person in there during the minimum 15? One direct care staff person for every 15 residents during the walking hours, and then one person for every 20 during the non-walking hours. Can you determine that? Can you determine whether you need one person or 2 people?
Well, it's waking hours, but that's an assisted living. They do go lower in memory care. But as I testified to on Tuesday, unfortunately, you don't know when the acuity level of your patient or your resident is going to change. Unfortunately, with dementia, it can change in a 24-hour period. So, you have to be able to respond to that fairly quickly. And so if you have 2 people there, then you're sort of prepared for that occurrence of, 2 or 3 folks' acuity level jumping up, I guess. It's sort of a preventative safety measure to me to have those 2 people there. And I get it that it's more costly for a provider. It's costly for somebody to put 24/7 security on their building, and they may never have an incident, but they had to pay for it for that protection, right? So I feel like it's for the safety of the resident. But I understand that it's costly, and I'm not a provider, so I can't speak to that.
And thank you again. I will just add one thing to that, Representative Jackson, just to be clear on line 15. It is always the case in the world of long-term care, there's usually in rules and regs that are promulgated by the department language such that you see in line 15 that just needs to be made very clear, regardless Based upon the needs of your residents, that ratio can fluctuate. So now, and I would also add, Representative Jackson, the author, to my knowledge, is not changing anything as to those ratios. Those ratios are what are in current statute, and they will remain the same. But I just wanted to point out that always that ratio can fluctuate based on the needs of the resident. Every provider should know that to be true. We're going to try to knock out the balance of these questions. Representative Allen?
Mine will be quick, Mr. Chairman. It may be, someone on the panel may have to help me with this, but to Chairman Lumsden's question, I think that was a relevant point about the technology. I know we passed in the House last year the camera bill, but is it true that it did not cross the Senate?
Correct.
So that would be, no, because I think that's an important component of this that Mr. Lumsden brought up. If that were in place, that may make a little bit of difference, but right now that it's still unlawful for a family member to have a camera for their own purposes in the room of their loved one.
Well, now that particular measure related specifically to skilled nursing facilities and not to these facilities, but as I recall, but that is
Right.
So that is a good point. I
Okay.
appreciate the point.
Well,
Well made.
It actually is lawful, though, just to clarify. It's lawful for them to have a camera.
Let's go to Representative Gamble.
Yes, I appreciate you being here today and helping to clarify some of this. Do you feel that a resident and or their family should have the ability to choose the level of care that they receive?
Well, not necessarily, because, I mean, they need to be guided as to what level of care is provided in each of those settings. Typically, somebody with Alzheimer's starts in assisted living when they're maybe in the middle stages. But at some point, typically, the community will say to them, you know, it's really time for them to go into memory care. And that's primarily because of the secured unit. You know, when you have someone who maybe is starting to wander or become more agitated, when you try to redirect them away from going outside, that memory care unit offers that security. So I think in most cases, it's actually the community that drives what level of care that they're in. They're going to advise the family. But there are families who hire in an extra caregiver who can afford it. That's, you know, atypical that you have the money to be able to do the assisted living plus the extra care, but some do.
Thank you.
Ms. Boatwright, you are very popular today. All right. Representative Mitchell.
Thank you. And this might actually not fall into your space, but listening to the questions about both folks' needs changing rapidly, so someone would need more care in one day, and also the idea that or appropriately staffed. So if someone's needs do change abruptly overnight and the facility does need more staff, how easy is it to hire in facilities right now? Do you generally have an overabundance of folks you could just pick up as needed?
I'll take this one. Thank you, again. I think that's we've had several questions that really aren't quite for Ms. Boatwright, but I will. So there is a crisis with an inability to hire today, especially for, as you might imagine, in a state that's thriving economically like we are. Jobs like we just described, where you're changing adult diapers, are not the most glamorous and not the most desired. And so I think that we're listen. This is great debate and discussion, but I do know that both sides are coming from this. Both sides want the same thing. It is increasingly difficult to hire and retain employees, and I think the author is trying to find flexibility to meet the standards that are in statute, but to have flexibility to do so. And I understand why that is because of that. But yes, it's rather difficult to hire staff these days. Very difficult, and worse every day.
Thank you.
If you did see that change where all of a sudden you did need to exceed the minimum, unless that's sufficiently high with the two people already there, it may be quite challenging for you to find someone to address that in the short term.
I'm going to speak to that. So I'm going to go back to the example of a 100-bed facility. I don't remember the exact ratios, but I have an example because I'm involved with one where there's about 100 beds and there's 80 employees total, because we're providing care 24 hours a day. watchful oversight 24 hours a day. And so you have you're covering 3 shifts a day, 24/7. And so for shift A, you've got a mirror of that on shift B. Because if you work on Monday, you need somebody else to work on Tuesday, so you can have a day off, So typically what happens is if more staff is needed, you call in somebody on the team that is willing to pick up extra hours, or maybe hasn't been working full time and has time available to do that. So that's usually how that's covered. Chairman Petrie is exactly right. The workforce crisis we're in right now is extremely challenging, more challenging than I've ever seen it. And but that's usually how we fill those holes.
Thank you, Chairman Petrie, for volleying those questions about staffing. And I just wanted
No, they're
to
important. Thank you for being
say
here.
that the workforce issue, there's a new facts and figures coming out from the Alzheimer's Association. It comes out every year. It's coming out on the 15th. Every one of you will get a copy in your box. But the top issue in there is direct care workforce shortage, and the association stands ready to work with you to solve that problem.
And y'all have, the Alzheimer's Association is dear to me. I have supported them for many, many years, and y'all have supported the long-term care industry for many, many years. We know, again, how important this is to you, and we recognize you're coming from the same, everybody has the same goals in here. Thank you very much. All right, is there anyone else, because we need to move on this, anyone else who would like to make brief remarks? Yep, Tom? Anyone else? Okay, just Mr. Bauer? Nobody on deck, okay. Mr. Edge on deck, and we have, right, Cash, you as well? Or, okay, just Jason? Okay,
Yeah.
gotcha.
Very briefly, Mr. Chairman, Tom Bauer with Leading Age Georgia. I think you actually made a couple of the points I wanted to make, and that is, I think what this bill is trying to do, and I don't have the exact sub in front of me, but 987 addressed 2 direct staff on site at all times. And when the rules came out, it talked about having one on the occupied floor. And that's what went beyond 987, and I think that's what Chairman LaHood is trying to address. He's not trying to lower the ratios, but he's trying to deal with that provision, if I understand it correctly. So, just for what it's worth. And yes, you're right about the shortage, because we've got people who would rather flip burgers because they can make more money than changing diapers.
Well, thank you, sir. Mr. Edge?
Mr. Chairman, members of the committee, I'll be very brief. I represent the Georgia Senior Living Association. We represent the assisted living communities and the personal care homes. This is a very delicate balance we're dealing with here. That's the bottom line. We're trying to balance the needs of the patients versus, frankly, the affordability and the ability to provide these services. It's hard, but I think in the spirit of 987, we're doing just that with this piece of legislation. I commend Representative LaHood for bringing this to the committee and to the General Assembly, because due to many factors, including the workforce shortage we have, our caregivers are facing a crisis as well. And frankly, we need the interpretation provided here to make sure we can continue to operate, provide services. We're going to be in a world of hurt if we cannot. So I think it's a well thought out measure. It follows the intent of 987 that y'all passed a couple of years ago, and we commend it to you.
Thank you, Mr. Edge. And Mr. Brose, or is it Tony Marshall? Mr. Marshall? Good to see you, sir. Thank you for being here.
Thank you, Mr. Chairman and members. Tony Marshall with the Georgia Healthcare Association. And I want to be real clear from our perspective. We fully supported House Bill 987 and the intent of the bill. And we feel like that there, unfortunately, with the way some of the rules were developed, some unintended consequences that have caused an unnecessary burden on providers that we didn't anticipate. frankly, looking at the definition of on-site, none of us expected an interpretation that would require a physical presence at all times in those units. We expected on-site to be more inclusive of our properties and communities. And so when we looked at those interpretations, and we've expressed that concern throughout the rule process and the public hearing, and we think the chairman's goal here of doing this is not intended to minimize the intent of 987 and the protection and safety of the residents, but to address a real-life situation in which the interpretation of some of those provisions has prevented access to care. We have some providers that had fully intended to build memory care centers, 5-star nursing home members that were going to build memory care in their assisted living units. And they've had to, because of the interpretation of rules, put those million-dollar projects aside because they did not find them to be financially feasible based upon some of the financial or the interpretation of how these staffing requirements should be met. So again, the intent is not to undo anything that was in 987. It's to provide proper interpretation of how you measure those guides, and that's really the intent, and we support the efforts to do that.
Thank you, Mr. Marshall. Any questions for Mr. Marshall? Okay. Thank you, sir. Thank you for being here. Is there anyone else that wants to speak to this measure? Okay. All right. Mr. Hood, is there anything else you would like to say?
Yeah, I would like to
Finally.
add, thank you for all the testimony. I appreciate it. Listen, I totally understand and respect the caution that I feel. That's a good thing. We shouldn't pass these kind of measures, willy-nilly. These need, a good, thorough debate. One of the things that was brought up was the pay for direct caregivers, and that's one of the very issues this bill will help to address by a provider being forced to overstaff in situations. We're having to dilute the resources that are available to pay the staff that's there. If we can concentrate the staff where they're needed the most, the providers will have the ability to pay them more competitively. And so, again, I understand the caution, but I need you to remember, before House Bill 987, the ratio was 1 to 20. We've lowered it to 1 to 12, but because of an interpretation, like Mr. Marshall just mentioned, 1 to 12 is not recognized. There's no situation where 1 to 12 happens when there's 12 or fewer residents. And so, and the other thing I'll add to that, DCH did have a public comment period when the draft rules were presented. Well, I know of at least one association, I think there were a number, that tried to tune in and give comments, and either the technology didn't work, to do the virtual hearing, and the comments that were submitted were not responded to until after the rules were adopted. And in addition to that, a lot of the leadership level staff at the department retired immediately after that process. And so now they can't be asked questions. And so this bill is a common sense measure that will help to keep the doors open for a vital service that's needed in this state. And if you've never looked a family member in the eye and said, "I'm sorry, I can't accommodate your loved one because you're $500 short, and I can't do it for any less," that's a tough situation to be in. This bill will allow us to expand access, make it more affordable, pay our workers more, and it's a win-win for all.
Okay, all right, so the chair is going to ask I'm going to ask Deputy Director Hood to come forward, if you don't mind. I hate to put you on the spot, sir, but I'm going to ask you to come up here because I have so much respect for you, and I mean that. I'm sorry. We're changing up here. We've got so many committees going on. This was going a little longer. Yeah, a little longer than, yeah, we may have to change up again. Y'all got somebody else to tag team on this? All right, Chairman Hood, Deputy Director. I got too many hoods and LaHoods up here.
Yes, sir.
I do indeed have great respect for you and your leadership. I want you to know that. And that has been born out of working with you for years. I just want to ask you a couple of things to make sure, because it's real. I think we all understand that everybody here wants the same thing. We want to make sure that where there's flexibility to make sure we can best serve people and serve them well, that we have that. But we certainly don't want to do anything to erode that. Everyone here wants just that. I wanted to ask you, first of all, if you have anything you'd like to say, but my question is, I know some of the language that was changed, was it beneficial to the department in some of the language, and or some of the changes in terms of how we worded this going to be helpful? And also, do you have any concerns about your staff at HFRD being able to fairly survey based on these changes?
Okay.
Thank you, sir.
Thank you, Mr. Chairman. So I do think that the changes that the committee suggested on, that if you're looking at a monthly average, if that's the intent of the committee, that's certainly what we would need, and I appreciate you leaving the weekly so that we would have a corrective action if we were to have a complaint or so forth, so we would have intent there. So I do think that clarifying language is helpful, and I don't know that this was pointed out, Betsy helped us with that. We clarified and added that we had that clear in all licensure types. So I think we have personal care home, to my understanding, as well, and we put it in place with Chairman LaHood's assistance, where we were not touching existing law before, to make sure we were consistent throughout, to my understanding. So I do think, to answer your question, that's clarifying. And then we also, as I think was referenced, put a clarifying statement at the end to make certain that it's clear that we're looking for one of the three types, that we're looking for a CMA, an LPN, or a registered nurse within the scoping of, if it's two at all times, it would be, it could be two CMAs, for example, or if it's one it's got to be one of those three. It's not cumulatively three people at one time. I think that's helpful if there's a misunderstanding. On either of those, that's not how we were surveying. So I do want the committee to understand we were surveying to the extent of what y'all are clarifying to. But I do think it's helpful, and certainly if y'all agree that clarifies it on your behalf. With the changes, the only thing that I would reference there is you have to recall, from our standpoint, this is a certificate program. So this is an independent add-on to an assisted living license, and it's a certificate. And this language that is in statute is specifically in memory care for that certificate. So the department's understanding is, when you say two at all times, and we've got a separate ratio, and we're saying two at all times on site within the certificate, to us is a separate facility. It's a locked facility. I understand I just want to make sure that that's clear to the committee. When we look at that, we see that as a separate facility to survey. So if someone elopes and there's only one there, elopement meaning someone left in the middle of the night, and we go in there and there's only one person there, and it says clearly in statute two at all times, that's how we're going to, it seems to us that's fairly clear that that's speaking of the memory care unit. I understand the discussion and certainly understand what you're talking about if they stepped away, for example, during mealtime, an emergency, or what have you. So I worked with Chairman LaHood. I do think the on-site language originally we could not survey to. I do believe we can survey to this, if this is the committee's intent to do that, because it's clear, right? And that's what we're after from a department standpoint, is that it's clear and everyone understands it, that the providers understand it, and that the community who's paying understands that's what the staff ratio is.
Thank you, sir. Any questions of the committee so we can move forward? Okay, I see none. Thank you. Thank you, sir, again, for your help. Okay, I think we've heard all we need to hear on this measure. I think we can all agree on that. All right, what is the will of the committee in this measure? All right, we have a do pass and a second. All right, any discussion from any members? Representative Allen.
Yeah, before we take the vote, I just want to reiterate that after looking at the language, I'm going to vote not do pass, only because I firmly believe that we are still going to have the same interpretation issues that we have now. And the rule is what needs to be readdressed, not legislation. So I just wanted to make that statement.
No, thank you. I appreciate that. Any other questions from the committee? All right. Representative Hood? Chairman?
This comment is just directed to Representative Allen. I appreciate, where you're coming from. Mr. Hood from the department just told us that he could survey to this language, and what this language would do is it would trigger them to update the rules that they could clearly survey to. And so that's my argument to that. And I'll just say one more time that this is not something that's I have any question about. My family's been in this business for 44 years. I've been in it my entire life, 25 years as a professional, and I've seen how these facilities operate, and I see this as vital to keeping a lot of these open. And you heard Mr. Marshall say that reputable businesses, companies have determined that the business model just simply does not work without clearing up the interpretation. So a yes vote is a vote in favor of senior adults in this state and making sure that we're doing all we can to provide more access to care that's needed. Thank you.
All right. Any further discussion by any members? This has been very helpful debate. All right. We have a motion do pass. We have a second. All in favor, vote aye. Aye. All opposed? No. All right. The ayes clearly have it, and this bill will advance. Now, we will go to Representative Moore, HB 1427. I don't have any control of the air conditioner. I'm sorry.
Is Representative LaHood still in the room? Is he gone? Where is he? Oh. Where? Okay, I really need help. I can't see him from here. I want to move on so I can get you all in and out of here. But I promise you I'm going to check into...
Hold on 1 second, Representative, 1 second.
Okay.
Thank you. Hold on 1 second as we...
Well, that cleared the room.
Around a little bit. Okay. No. Just easily. All right. Representative Moore, we look forward to hearing from you on House Bill 1427.
Yes, sir.
And we understand you have a guest with you today, a lovely lady I got to meet out in the hall, Miss Christine Priester. I'm excited about hearing from her today, too.
Christine.
And so the floor is yours to explain to us your
First
measure.
of all, I just wanted to say I've been in so many committee meetings that I'm going to have to check into a memory loss center because I came and sat down and started taking notes today. And I was taking my third note when it dawned on me, I'm not on this committee. I'm going to memory loss rehab this weekend. So thank you all very much for coming back to hear this bill. I do appreciate it. The bill, 1427, is here in order to help to strengthen the laws of home health care facilities and home health care aides. You all got the bill in front of you there? All right. It seeks to provide cardiopulmonary resuscitation certifications, CPR, for all home health care aides, for backup aides to be available at all times in homes, as well as coverage for liability to make the home health care agencies more responsible for their aides. And so it's very simple, and it should be a very clear seamless cut, but I know that it's not like that all the time. So I wanted to let you all know that this bill was just a little bit personal for me because for the last 9 years, I've been the caregiver to my father until he passed in last March this time. And in that time, in the 9 years, I've had to go off to work like many of us do. I've had to campaign like many of us have. And I have to leave my dad in the care of a home health care aide. And in many instances, the home care health care aide didn't show up. And there was no backup for that person, and I couldn't make it. And that would be a heck of a thing to have to do when in the middle of session when I have to stay home and take care of my dad. My dad was a colonel in the United States Army. He's a 2-time Purple Heart recipient in the Korean conflict. And so me having good health care attendants take care of him is only fitting and proper for a Colonel Daddy. Just wanted to say that. So during this time, not only was my dad left alone and I'm on my way to work, and then I find out when I get home that my dad is still in the bed because he was disabled. He couldn't get out of the bed by himself. He had not had his medication, had not had his food. He had urinated and defecated on himself all day. And if I stayed to kind of linger on at work or put in an extra hour or I don't drink, but maybe a meal afterwards, that prolonged the time that my dad, I'm still there, would be alone in his bed. And I would not know until I get home because he could not reach for a cell phone. I found out that I wasn't alone in this, that there are thousands of families out here in the state of Georgia who were going through the same thing I was. But I was so bogged down in taking care of my daddy that I did not look around or seek or look out for other, groups that were doing the same thing I was doing, other families. Because my every day, taking care of one elderly man is worse than taking care of like 3 little kids that I've reared, plus all of the foster children, and now my nephews that I have custody of. So taking care of one senior person is amazingly debilitating on one person. So when the aide doesn't show up, we have a problem. I would like to see the home health care agencies have a backup plan. There should always be a PRN person, an as-needed person. They can at least, at bare minimal, come over, give them their medication. In Miss Christie's case, get her out of the bed. And in my dad's case, get them out of the bed so that they can be self-sufficient in their chair. Oh, what my dad could do once he got in his chair. He could flip an egg in a skillet pan. He could go outside and smoke a cigar all day, and my entire community would come to his aid and bring him a hamburger. They waved at him, and he waved back. So it's important that someone comes and checks on them. But if I don't get a call all day, when the nurse aide is there, I feel like things are going well. I come home, Grandpa's clean, and he's eating, and he's sitting in his chair waiting for me to tell me all his work that he's done the whole day with his cigar in his hand. Even our I dare say our mailman would go and get his lottery tickets for him. That's the kind of personality that he had. He was engaged in the community once he got out of the bed. So, secondly, I wanted to address the issue in this bill about the liability that should lie back on the home health agency itself. And that would be because many times, and I'm not the only one, I have thousands of stories from other families where home health care aides come in and they steal from you. And when they come and they steal and they destroy your property, there's no one to blame. What are you going to do? Sue someone who makes $9 an hour? Or do you go to the agency and the agencies will say, oh, we don't have any liability in that. They're a 1099er. Well, the law provides that if you can tell someone where to go and what time to be there, you are their employer. If you are taking, and you should be taking taxes out of their paycheck like anyone else, just like you and I, they are an employee and not a contract worker. But I did cover this in the language, whether you're a volunteer or whether you are a contract worker or an employee. I think that the agency should have a responsibility. And in one of these conflicts, the young lady came into our house, probably like I did, sitting here in a chair, thinking I'm a part of on that side instead of this side. She turned on the water in the kitchen. She turned the knob, and she walked out. I didn't come home until 10:30 that night. I have a 572-foot driveway. Water was all the way down, out of my garage, out of my kitchen, and down at the mailbox. My water bill for that one day was over $1,200, and I have $68,000 worth of damage to my home. That includes the floor, subflooring, and joists in the not only in the kitchen, but the pantry, the laundry room, and the family room. And so in that, my floors were so damaged that my father's 240-pound chair, plus another 150 pounds in it, could not travel from the bedroom through the back door where we have his ramp. So I was left devastated there with a lot of damage. I went to the home health care agencies. They refused to take service when I did try to sue them. And they locked their doors and no one would answer. I took a special process server. I have never been able to serve them in the time allotted by law. So there was no one to take responsibility at this time. And when we did get them on the phone, it was, we don't have anything to do with that. Talk to the aide, another $9 an hour worker. So they're not held responsible for when people come in and damage. They've knocked over things in my home. In one lady's house down the block, the lady smoked a cigarette, thought she threw it in the toilet, and set the trash can on fire, burnt their entire house down. The bathroom that she used was close to the garage. It set the bathroom on fire, set their gas cans and their equipment that they use in the yard on fire, and it exploded the whole house. And it was everything I could do was to go in there and pull a 180-pound woman out, and I have sciatic nerve damage. So I just happened to notice the house on fire while the woman was on the other side of the house, and her whole house burnt down. The agency took no responsibility. This is just 2 instances, but there's thousands of others out there, and I realize that I'm just not the only one. Lastly, and the most important thing, when you leave your child at home, you're a disabled parent, disabled adult, paraplegic, whatever, you want to know that while you're gone to work, that the aide herself, and not to be misconstrued with certified nursing assistants who are certified. They go to a graduate approved school for certified nursing, and they pass a nurse aide exam here in Georgia, and they become a CNA, a certified nursing assistant. But home health care aides do not have that requirement. You want to know that when you are gone, that should one of your loved one choke or stop breathing, that they can enact the 911 system, which includes picking up the telephone, calling 911, and starting either cardio resuscitation or being able to use the Heimlich maneuver. In this, CPR training is free in the state of Georgia. So there's no cost to bear on the agencies themselves. As well, CNAs in the best of light are making somewhere between $27,000 a year if they come to work. That is the medium for the best paid. And getting them CPR certified certainly would be more attractive, especially in Medicaid facilities or Medicare homes that are paying the bill. So I would like for you all to please take a look at this and consider that we should, number one, make sure that our home health care agencies are held to a higher standard, because it does incorporate our homes. That they require that their employees are CPR certified, and that they, at bare minimum, have someone, even if it's someone in the office, to come and check if they can't get a hold of the aide. Because the typical scenario for an aide is, I just don't feel like going today. They don't answer their phones. When you call the agency, the good agencies will answer, and they will try all day to find someone to come out to that home. If I had an agency, I'd just send myself or someone else to come and check to make sure that they're okay, but they can't get in touch with their aide either. And they have no idea how devastating it is. Had the aide done what she was supposed to do with my father, who ultimately died of stage 4 ubiquitous ulcer on his backside, which means that she did not clean him properly because she only came 2 out of the 6 days that she was required to come. My father would not have gotten the bed sore that went all the way to his bone and eventually took his life.
Representative Moore, that is a terrible story, horrible examples.
That's why
And
I'm here.
I want to make sure we have time, in the limits of time, to ask you some questions. I want to ask some questions first, because I'm very confused about a few things, and I do
Yes,
know
sir.
a great deal about long-term care and certainly about home care, and so I'm confused by the things that you are asking for, as I understand it, having done this for over 30 years, are already required. So I'm trying to understand how a licensed home health agency, you're saying, in the state of Georgia, did not have liability insurance, was not bonded, was not most of the things in these provisions, if you're a home health agency, and remember, there's a difference between a home health agency and a home care agency. A home care agency is what would be licensed by DCH as a private home care provider. So that is a different entity altogether. Your bill expressly relates to home health aides and to home health agencies. So only to Medicare certified home health agencies. My understanding, and I've had quite a few of the hospital folks speak to me about this, is that those things are already all required under Medicare rule. So I'm trying to understand, were you dealing with an agency that was unlicensed, because that happens all the time, sadly, or were you? I don't know that I understand. So
Well, 4 out of the 7 agencies that we used were through Veterans Affairs. And
4
they
out
had
of
to be
7.
vetted. We've
Okay.
been through 8 agencies.
So, now, let me, and just not to cut you off, but was Medicare paying? Were these home health agencies, or were they private home care providers?
They were home health care agencies.
All right, they were billing Medicare
Yes, my
under
dad's
certificate.
Medicare.
They were certificate of need,
Yes.
licensed
And
home
they-
health agencies billing
Absolutely.
Medicare.
Absolutely.
Okay, that's okay. All right. So I think I can almost guarantee you, from the description, they were already operating out of the law.
Well,
So
now
so that'll be the conundrum as we look at this, is that again, being any organization that has no liability insurance, not only is that that's absurd. I mean, they're putting their entire they're putting everything they have at risk. So I don't know anybody that operates without liability insurance unless they're outlaws. And there are outlaws out there. And so
Well, they're not
there may be a
supposed to
better way
call
of
their
looking at this measure.
employees a 1099er either. And they absolutely do.
They cannot use 1099s according to the statutes that are already in place in this state.
Exactly.
That is correct. So again, most of the things you allude to are really, and that's why I felt like a hearing was what we needed to understand you and to be sensitive to your concerns. It may be that your direction should be in another title. You may be
I
dealing
can
with
amend it to
unlicensed
do that.
providers. You may be dealing with unlicensed providers. I don't know that. I don't know who's investigated these things, but I think that's what we need to understand.
Well, I work with DHR on this as well, and they defined it as home health care agencies and home health care aides. The aides can obviously work in Medicare facilities, but most of them are working in home situations. So in that, when Veterans Affairs picks up and they have a slew of agencies that they use for their veterans, they send them out to our homes. The one in particular did not have insurance, and they were not required to have insurance for the aides, for what happens to their employees in someone's home. And this is what the Veterans Affairs stated to me, because for myself, I thought VA should be responsible for the damage in my home. Not only what they did was just bring a ramp, which they charged me for, to get my dad out of the house, because there's no other way for him to get out of the house.
Right.
But to answer the question, they say that they have a level of insurance, but not to cover their employees.
Well, I'm going to recommend something. We have a question here, but I want to
Yes.
make sure we also get to Ms. Priester. So I'm
Yes.
going to, in the interest of time, I am going to make a recommendation. I hope Mr. Hood doesn't mind this. I'm going to recommend you speak to Mr. Hood in the back, who is with the Department of Community Health. So the Department of Community Health, under a division, which is the Healthcare Facilities Regulation Division, regulates all of these facilities. And if you spoke to the DHR side, you weren't dealing with the people that regulate these folks. That's DCH.
Right.
And so I'm going to encourage you to speak to them. And then maybe when you learn, let's discover more, because again, most of the things you're talking about, in other words, I hope you see my point. I'm trying to be helpful.
Right.
If we don't change statutes for people that already aren't following statutes. I mean,
Well,
if they're not
because
following the
there's
law,
already a law, there's a
so
law.
these things are already, as I understand it, required. Now, that doesn't mean that I believe you. You say the folks that were serving your daddy weren't doing this. I believe you. I just don't know how they were doing that. Let's discover that.
I don't
Let's
know
discover that.
what the status was, but I would assume that if the federal government hired on or at least contracted out with a list of agencies, that they should be everything.
I would never assume the
Department-
federal government does anything right, if it were me. So that would be where I would begin.
But in my defense, I did have 3 full-length meetings with Department of Human Resource and some of the commissioners there, and they brought their whole staff in so that they could talk to this. We talked right before Christmas. I asked them to take their entire Christmas break to think of the things that they felt like should be in this, that it should be simple. The commissioner went over it herself. We discussed it again right before session, and that is how I came up with this.
That's
It was
excellent.
determined that it was home health.
So, Representative, like I say, and I
Yes,
think
sir.
I would let Mr. Hood know who those discussions with, so he can collaborate with his colleagues in the other department.
Absolutely.
But I think that'll be helpful to you. We have a couple of questions.
Yes.
Representative Hill has a question for you.
Thank you, Representative Moore. I know what you went through because I did that with both of my parents.
It's
And
horrendous, isn't
my
it?
old dad was a Marine from the same war. And but when I dealt with the VA, they only gave us a allotted amount of money. They didn't actually give us anybody's name on who to get. Was that the situation with you?
No,
I'm
no.
just curious.
What they do is you have a veteran. My father was a commissioned officer, and of course, an officer and a retired officer at that. They send and I think this is fair to say for all veterans today. What they do is that you apply, you're determined that you're disabled and you need help, and that's a process. So once you get there, they will choose an agency that they have contracted out with. They have a list. They have a whole section there that deals with home health care providers, home health care aides, home health care facilities. They choose one. You don't get a choice of who comes out. They have already vetted these people and the agencies, and they send them to your home. In one lady's case, and I do want to say this to you all, just so you know, it may not make a difference, but apparently the VA sent out a young lady who had come here during the flood from New Orleans, and she was wonderful. I was gone as a Hollywood publicist. I was out at the Oscars, and she went in my dad's room, and she found his debit card, and she took him to the bank to go so he could get cigars. She went back every week to take money out of his account until she completely drained his account of $18,932.33.
This is getting worse the longer we go.
Well,
This
it's
is
the truth.
You
You
weren't
need to know
hiring
what's
people off the
happening.
street now, right, Representative? That's terrible.
The VA
I mean, we-
sent this young lady.
The-
She's in jail.
Mr. Hood needs to know about, okay, she's in jail.
She's
Well,
in jail. Watch
I'm
it.
glad to hear
She's,
that.
She can't pay restitution even if she tried.
Trying to get
They've taken her CNA certificate and she can no longer work with elderly people
Gotcha.
again. But what they did not do, because they failed to do a background check, is that she had 2 felonies in the state of Louisiana against elderly people.
Yeah.
My dad was
Well-
nothing new. And how the GBI found her was on social media.
Well, Representative, I want to make sure we hear from Ms. Priester and Ms. Reeder real quick, but I do want to tell you, to your point of that what you just raised, remember, now in Georgia, the law requires every caregiver for any organization, it doesn't matter if it's home health or any other long-term care type setting as a caregiver, a fingerprint is necessary, a live scan fingerprint for every caregiver.
Well, this must
So
have just
there's a
happened
litany
since
of
my
things
dad
that failed
passed.
in your case, and I'd love to really understand how that happened, and I do believe DCH can be very helpful to you. Ms. Priester, I'm going to ask you if you can move up here to this mic right here, what we have as number 4. And Representative Hill, if you'll just move that for her, I want to make sure that Ms. Priester has come a long way to be with us and talk to us, and I want to make sure she has that opportunity. We can probably hear you anyway, but you.
I'm used to talking loud.
You go right ahead, ma'am. Thank you.
First of all, thank you all for having me to be able to come and share with you some of my experiences and some of the issues that I want to talk about. First of all, I was in a hit and run bicycle accident back in 1986. Don't feel sorry for me, please. It was an accident. I look at it that way. A lot of people say, did they catch the lady? I said, I don't know whether they did or not. It doesn't matter. It was an accident, I believe. And life goes on. So at 26 years old, in the prime of my life, I had to go through a whole transition as to what I was going to now do with my life. Prior to that, I used to be a CNA. I worked in a nursing home, a terrible one at that. And in trying to make differences, it wasn't at the time when they were ready to make differences and changes in policies, procedures, and things that were going on. These issues that we're talking about are not something that just started. They have been going on. I mean, this is back in 1970s, the 70s, when I was working in a nursing home and trained. One of the differences then as opposed to now, my training to be a CNA was 3 months. Now you can get a license as a CNA in 2 weeks. Yes. What they actually learn, I've looked over the materials and been through some of the trainings with my CNAs that have actually been through school. It's crash course, and what they actually learn to apply is another whole issue. However, moving forward to where I am today, my whole issue in purpose in life is about trying to eradicate abuses. Because abuse starts from when we are children, moves into when we are teenagers, young adults, and then all the way up to as seniors. I've been through the whole faucet of it. From child abuse, now I'm going into being a senior, don't tell nobody. And having to deal with CNAs, from actually, I'm going to clarify something about the home health care definition in the home health care and the health care that you have in your house. One is in a facility and one is in a home. You have a crossover of all the CNAs going from one to the other. You know, if they're working for an agency that might require them to be certified and have CPR training and all this here, that doesn't mean that the ones that are working in the homes do. So there, because of this shortage of the need for CNAs today, people are pulling CNA workers, family workers. I'm telling you, you can send me an alien, and I will use an alien to get me some help today, because that's how bad it is. Fortunately, I'm here today to be able to share my story with you because of my significant other. That has been my primary caregiver. And without him, if I had not had him in my life, I would have been dead 3 times from being left in the bed, and not just for 1 day, but 3 days. They couldn't find an attendant for 3 days. And when I talked to the owner, the business owner of the company, and I said, well, look, you can't find no one? You come out here and help me. You know, I don't care. When you are laying there and you're totally dependent, I can use my neighbors for so long. Okay, they're not trained people, and they don't look at this and coming in to help somebody who's being left and not cared for too lightly. Well, maybe we should call the police. Who are the people who govern this? You know, I'm having to train them as to what the industry, what is happening in the industry. Not only my neighbors, but the caregivers. I want to check for being a therapist. I want to check for being, you know, this motivator in this person that I have to be to caregivers that are coming in that don't have no clue about what they are doing. In the last month, I've had a young 20-year-old come in who was a student at Kennesaw State. She was beautiful, wonderful personality. Never worked with anybody in a wheelchair before. Never worked with anybody who was elderly or sick. She got into the business because she said that her mother was somebody who needed some help. That's what, gave her the criteria to do what she was doing. They hired her at some agency with no credentials, none. I've had in my community, the DeKalb area, the people that they're sending out, I'm talking about women that have a heart and care about what they're doing. But we are living in a society and in a culture of people that's filled with so much dysfunction. You have my caregiver here today. She's 25 years old. She has 2 children. She has rent to pay. She has a car note to pay. She has child care to pay. And she's trying to do all this, start her own business, which I'm trying to motivate her and encourage her to. And hopefully she will find her way, with all these here things to juggle in her young life. We all have grown up and made mistakes, bad choices. Oh my God, my life is full of them. But I decided I wanted to give back, and I do it through my writing and through poetry. I worked the business for 15 years, which was the Atlanta Child Care Guide that helped people, Child Care Resource and Referral Service. And I did that, and I was knee-deep into making differences with child care, which on the young end of the spectrum, dealing with children, and now with the seniors, we have the same issues. Ratios and dealing with child care, you cannot put a person in an infant room caring for 4 children. You have to have at least 1 to 4 is what the ratio is. And when you're dealing with somebody like me, I'm totally paralyzed from my chest down, and I need help with getting dressed. I am in an infant position. You know, it's not a position that I chose to be in. I was in an accident. But in order for me to keep going on and living a life where I don't feel devalued, where I don't feel like a burden to society, and where I can try to give back what I can, you know, we have to have laws and legislation and bills that are here to not just protect me, but your turn, your turn, your turn, and your turn is coming, God willing.
Ms. Priester, you make great points today. We're so glad that you're here, and I think your point is well made. We all need to be concerned about the quality of care that individuals are getting when they're getting home care. I know you heard my comments earlier. I think we need to learn more about what happened here to better understand it, because there are a great deal of requirements in place for licensure. So we're going to work on that, but I want you to know how much we appreciate you being here today. And I think, and Miss Reeder is your caregiver then.
Yes,
and
ma'am.
she, and you had, my understanding is she wanted to speak to us briefly as well.
And I
Is that
have
correct?
something I want to leave you with, which was my last book of
Please
poetry.
do.
It's called Metamorphosis, Met, Love, and Changed.
Metamora, okay.
Okay? And it's all about, you know, recognizing the issues of abuse. But it was put in a poetic, if you read it, I'm sure you'll be calling me. And I'm going to leave you with all of you with a book. And I'm not going to sign it until you read it and call me and tell you what you think.
Well, you were too kind. It was delightful to meet you.
Thank you.
And
I met Miss
thank you for
Christie
being
on
here.
my campaign
And we want to,
trail.
and we're going to be working with Representative Moore to understand better the issue. And I think there's a great deal we can get from the Department of Community Health, who is absolutely dedicated and committed to protecting this population that we're talking about. So thank you so much.
I met Miss Christie on the campaign trail, and she had just gotten an aide who they found off of Craigslist. And the lady dropped her on the floor when she was getting her out of the bed and ran out to her car.
Oh, my Lord.
Well, after a while, Miss Christie and I got a good relationship going, and she was one of my best campaigners. She could
I
move
can see
faster than
why.
anybody else. She held up signs on the back and the front of her chair, and she went across the crosswalk at one of the busiest intersections in DeKalb County, back and forth, because no one was going to hit someone
That
in
is
a,
unbelievable.
in a chair. But she got their attention.
No wonder you
Miss
got
Rita,
elected.
you want to step up here real quick? Yeah, she was my best campaigner. She rode up and down the sidewalk in the rain, and she kept a raincoat on, and I'm surprised you don't have to bring those
Well,
here.
thank you, Representative Moore. We appreciate this. I know we've all got other
And we-
committees.
Miss
We're gonna
Rita, if
pass
we can
those
just
out.
get you to set those down and
We'll-
come real quick.
We'll pass
so we
them
can-
around. Oh, do you want to make a comment, my dear? Do you want to make a comment?
is.
Okay, yeah, let's do that real quick.
She's a little scared.
Don't be scared, my dear. We're all just proud you're here to be with us. We're proud that you're here.
She told me to push something, I don't know what that is.
Hi, my name is Destiny Render. I am her caregiver. I'm also certified as a CNA. I personally feel like everyone should be CPR licensed because you're dealing with the human health. Also, I have been working in this industry for over a year. My auntie who raised me was paralyzed from the neck down, so I know how it is to leave someone in the bed and have a BM left on them all day and not be attended. That can leave all types of bed sores and everything on someone. So it's very important for people who work in the industry I work in to be certified, because how would you feel if your mother or father or auntie was left unattended and they can't attend to them properly? That's all.
Well said. No, thank you so much. Well done. And we are so thankful. And Representative Moore, let's work on this, or let's you and I just stay in contact.
Well,
Obviously,
thank you.
you
Whether
know, we're
we
just gonna
have
hear it.
home health care attendant or agency, maybe we have the wording wrong that we can fix.
Yeah, let's look at it.
I would like to work with that, but I'd like to get this moving because the difference between home health care aid and not having CPR certifications and knowledge thereof over the next year and a half is just going to be devastating to a lot of other families.
Thank you,
And I
Representative.
wanted to thank Miss Christie. If you all need a
And
campaigner,
thank you for the book, Ms. Cree. Yeah, you need to come to Savannah and campaign.
y'all
for
come
me.
get
That's
Miss
right.
Christie. Not only is she the lady that can, but she also drives. She has a
All
van.
right, all right.
This
She
woman
probably-
drives
probably
her own
better than
van.
me, I know.
She drives. I've been tongue in cheek in the car with her, but this woman drives.
Thank you.
So let's give it to
All right.
our
Thank y'all so
disabled
much. And this meeting is
Thank you all
adjourned.
so much, and I'll thank you for consideration.